Welcome, everyone. A special speaker today. Matthew Jakubczyk is a clinical psychologist at the VA Puget Sound Healthcare System and is an assistant professor at the University of Washington's Department of Psychiatry. Dr. Jakubczyk received his PhD from the University of Massachusetts at Boston and trained at the National Center for PTSD at the Boston VA Medical Center prior to his internship and postdoctoral training at the Seattle VA. He served as the lead psychologist within Deployment Health Services at the Seattle VA since 2005, delivering direct clinical care to returning Iraq and Afghanistan veterans. Dr. Jakubczyk is also a faculty member of the Puget Sound VA Mental Illness Research, Education, and Clinical Center. His areas of research include PTSD and associated high-risk behaviors, primary care-based interventions for PTSD, and gender-related factors associated with barriers to mental health care. Today, Dr. Jakubczyk will present findings from a series of studies specific to PTSD and its association with aggression and violence, substance abuse, and markers of elevated suicide risk in Iraq and Afghanistan veterans enrolled in VA care. He will also discuss the challenges of engaging this cohort of veterans in mental health care and describe several innovative strategies being developed at VA Puget Sound to address PTSD in recently returning veterans. Dr. Jakubczyk.
Thank you. Thank you so much for having me today. I realize I'm competing with some beautiful weather outside, so I appreciate people coming. I'm going to be describing a series of papers that we've put out based on some of the data gathered at the VA Medical Center. But I want to first acknowledge that a lot of this work has been done with some wonderful collaborators, both folks here in the Department of Psychiatry, Stephen Vinoy and Deb Kaysen, as well as my colleagues at the Medical Center, Stephen Hunt, Miles McFall, Tracy Simpson, Brad Felker, Carol Malty, and some really terrific, gifted fellows and interns that have helped prepare some of this data for presentation. I also want to provide just a bit of backdrop to this talk. Just the larger issue of PTSD and high-risk behaviors is not a new topic. Following the Vietnam War, it was quite clear that the combat veterans that were coming back were struggling with aggression and violence and suicide, substance use. And when I came into the VA system as a practicum student in Boston, it was September 2000. And so the modal patient that I was seeing was a Vietnam-era veteran who was coming in often decades after his service. And so series of divorce, legal problems, chronic substance use were present, but these things had manifested over this decades after service. So when people were coming in, it was difficult to know often where to start to untangle this. Exactly a year to the day of me starting in the VA, the Twin Towers fell. And so I had a very personal reaction, as all Americans did. But also within a few minutes of watching this, my wife turned to me and said, "I wonder how your veterans are going to react." And I realized, having already concluded that the VA was going to be an academic and professional home, that my career and my experience going in and working with veterans was likely going to be very different in the years to follow. So I'd like to spend a few minutes talking about Iraq and Afghanistan veterans as a whole. And let me be specific. These descriptions are the veterans that have come into the VA Medical Center. Remarkably, more than half of the veterans that have separated from military service have come into the VA care. I think this is due to unprecedented outreach campaigns from the Department of Defense, VA. But these numbers that I'm about to present don't represent all Iraq and Afghanistan veterans. It's also not just likely, but almost a certainty that I'm going to slip into acronyms. And so OEF, OIF, OND are the names of the military operations in Iraq and Afghanistan. OND is the last year or so in Iraq and has just concluded. The other thing that's somewhat unique about this recent cohort of veterans is the involvement of the National Guard and Reserve units. And so what we see is that about almost half, slightly less than half of the folks that have been deployed were deployed as part of reserve units and may not have entered military service with the expectation they were going to be deployed. And that certainly has impacted, I think, how we think of our Guard and Reserve military members. Also, I do want to point out that currently the Iraq and Afghanistan veterans only represent about 7% of all of the veterans that we are seeing in VA care. Certainly there has been a lot of attention, I think very good attention paid to the treatment needs of these returning veterans. But I do want to point out that the majority of our patients are other era veterans and are still presenting in record numbers for first episodes of care within the VA. Nonetheless, I think for political reasons and also because of our societal reaction to these wars, the presence of Iraq and Afghanistan veterans coming back after deployment has transformed VA care. I think it's been a catalyst for restructuring VA care. The types of disorders that people are being diagnosed with when they come into the VA are primarily musculoskeletal disorders, followed very closely by mental health disorders. And if you just look at the prevalence, these are cumulative prevalence rates. So these are the rate of all veterans that have come in diagnosed since 2002. But what you'll see is there's a lot of complexity in their treatment needs when they come in. I do want to keep in mind for folks, in some ways, this complexity is not unusual for those of us that work in psychiatric medical hospitals. But I do want to keep the prototypical 23-year-old Marine image in your head and think about what it would be like to be 23 and to be dealing with these disorders. Also, not unique to those of us in mental health, the complexity of psychiatric symptoms is the norm rather than the exception, with more than a quarter of the veterans that have come into the VA being diagnosed with 3 or more mental disorders. And so there's this complex constellation of physical, mental health symptoms. There's been a lot of attention paid to mild traumatic brain injury, chronic pain. There's a significant overlap between PTSD and depression, and these constellation of symptoms are going to interact and inform people's efforts to return to life in similarly complex ways. So the overlap of the impact of PTSD, for example, on marital stress, working, financial stress, and difficulty integrating is going to be in some ways amplified and occurring simultaneous to the impact of pain, concussion symptoms. So it's a complex picture. One of our early answers to this complexity was to structure care in a way that anticipated it. So before I came to what was then called the Deployment Health Clinic, a wonderful physician, Steve Hunt, had, based on his experience in the Gulf War I, had petitioned hard to organize care for our returning veterans so that primary care services were offered in a co-located, collaborative fashion with mental health and social work services. We wanted one-stop shopping for folks when they came in. And this was designed to be the primary portal of entry into VA care. So that we could initially assess all of this complexity and coordinate care so the veterans weren't feeling that they were running around the hospital to different clinics at different times, and that the same 2 or 3 providers that saw the veteran on the same day would be discussing how to proceed with care. And originally we had structured the clinic so that every veteran that came in got a mental health evaluation. We organized this so that this would reduce stigma. This would just be a matter of course. So unless patients overtly refused, we went ahead and scheduled them with a mental health provider. And I describe this in part to give you some context for the data that I'm about to describe. It's within this clinic that people were coming in and they were filling out intake packets. We were using standardized measures to screen for PTSD and depression and substance use and aggression and violence. So folks were coming into this specialty clinic. Again, this may not represent the prototypical veteran that would come into general primary care at another VA. But we had positioned our deployment health, it was called the Deployment Health Clinic at that time, as this portal of entry, and worked very hard to set up and maintain relationships with vet centers, with our specialty PTSD and specialty mental health clinics, with our polytrauma centers. And Washington State is incredibly fortunate in that the Washington State Department of Veterans Affairs financially supports contractors, therapists out in the community who can see veterans at no cost. So if someone is living up near Blaine, Washington, there may be a provider that they can go see so they don't have to come all this way to a VA care. So when I describe this deployment health clinic, let me pull back the green curtain a little bit. Originally, this was Steve Hunt and a very dedicated master's level therapist. That was the clinic. And for years, they were, for about a year and a half, they were seeing every veteran that came in, and those two folks were doing all of the intakes. I was the third hire into the clinic. So it looks great on paper, but also imagine some very dedicated but worn out providers doing this care. When I came on board, Steve had already started collecting this clinical data and had gotten IRB approval to start describing some of this. We wanted to know who was coming in so that we could organize our program, so that we could figure out how to coordinate their care and what to anticipate. When I came in with my interest in high-risk behaviors, I kind of took over the research part of it and tweaked the packet a bit to make sure that we were assessing for things that would let us know who was going to be at the greatest risk of self-harm or harm to others. So I'm going to be describing two samples today, and I'm, in the interest of just being efficient, I'm going to describe them now rather than each paper that came from them. But we started collecting data in 2004 and continued up through 2009 in our deployment health clinic. Again, everyone is coming in, everyone is seeing a mental health provider, everyone is filling out this packet. In fact, in the packet, we didn't even start asking why people were coming in until 2007, because we were worried that if they had to report why they were coming in, that might change their response. But you're seeing the demographics. Primarily white, majority are men, almost half are married, mostly Army and Marines, which are reflective of the military facilities in and around VA Puget Sound. And more than half of them are Reserve and Guard units, and their average age is 31. This is a bimodal distribution, so people cluster around the 23 to 27 range if they're active duty generally, and we're seeing older veterans in the Reserve and Reserve and National Guard components. So of those almost 700 veterans, we also then start collecting data on those that we went on to refer to mental health care. And this was done in concert with the National Center for PTSD, so we took their packet of information. There was quite a bit of overlap, a lot of the same instruments, but we asked again when we sent people on to specialty mental health or an episode of mental health care, some of the same questions and some different questions. So I'll try to, as I go, I'll try to specify which data set the different papers are describing. The first paper that we put out was, as most of the papers that we put out, was driven by a clinical question. We were seeing a lot of folks with PTSD and depression and substance use. We were also seeing a lot of people that were coming in that were reporting some of the symptoms. They were having a lot of the hyperarousal symptoms of PTSD. They were on guard, but they weren't having intrusive memories, flashbacks, nightmares, and we didn't quite know what to do with them in the system of care. We ended up keeping the kind of what I end up calling the sub-threshold group in our deployment health clinic as best we could, because it wasn't clear if they should go on to the PTSD clinic. We weren't sure if this was just a period of readjustment. It was unclear. And again, our point of reference are the Vietnam era veterans, where if they've been experiencing these symptoms for 30 years, you can guarantee that, not guarantee, but you can certainly infer that without some sort of intervention, it's not likely that those things are going to go away on their own. But for someone that's coming back a year or 6 months from deployment and they're reporting these kind of subsyndromal symptoms, it's not clear if we should move them into PTSD care or if that's in some way going to be premature. So we were looking at these different levels of PTSD, little or no PTSD, what I called subthreshold PTSD, and folks that screened positive for PTSD. And this is all based on classifications using the post-traumatic checklist of self-report measure of symptoms. And what we found was a fairly predictable kind of stepped level in anger and aggression. Those with PTSD were more angry and hostile than those with subthreshold, and both had higher levels than the people without PTSD. However, what we found, which was, I think it confirmed our clinical impressions, the subthreshold people weren't any less aggressive. In fact, in specific items, the people with subthreshold, almost 40% of them said that they had threatened someone without a weapon in the 4 months prior to coming in, and 15% of them had said they had threatened someone with a weapon. That was higher than the folks in the PTSD group. So this subthreshold cohort seemed like they were certainly distressed, but again, we didn't know what to do with them clinically. And that's something I'll come back to. We did another paper on subthreshold. But this was a small sample, so there were power issues. We don't want to make too much of a business over a null finding. But there have been many larger studies that confirm this pattern of subthreshold PTSD and that these folks really are impaired. When people have tried to explain this relationship historically, fingers are pointed at military training. It's because we send people to war, and then how is it that they're going to readjust? Most studies have found that it's the PTSD symptoms, not combat exposure or military training per se, that predicts the aggression and violence. But certainly with PTSD, you can imagine there's a lot of increased hypervigilance, perception of threat. Physiologically, they're very reactive. They may have trouble problem solving in situations where they get angry, and so it escalates to violence because they can't find words or step back. These would be features of PTSD driving some of this. There's also an emerging body of literature looking specifically at the emotional numbing symptoms. And full disclosure, this is one of the things that brought me into the VA, was this idea of emotional dysregulation. So I've been keeping an eye out for these papers. But certainly there's a growing literature that people may be using anger to avoid other emotions. That if you get angry, you don't have to feel sadness or grief. And anger is a very masculine behavior to exhibit. Military certainly channels that anger and doesn't make a lot of room for grief training. So it may be that some of this anger and aggression is an avoidance strategy. The next, another paper that we put out on those that were coming in through our deployment health clinic was related to alcohol misuse. And the military in general has a culture, I think historically, of elevated alcohol use. I got a tacit approval of people drinking very heavily on the weekends. Certainly there's a growing body of evidence from longitudinal studies that people that are deployed come back and start drinking much heavier than they were even before they left. But just at baseline, Marines drink a lot of beer. And in our sample, we found that 28% of the folks that we had seen in a group of about 300 had screened positive for alcohol misuse. So they were driving while intoxicated, they were drinking despite a medical provider telling them not to, or problems with school, interpersonal functioning. We wanted to see if PTSD was related to alcohol use independent of depression, and it was. This was not surprising. Both PTSD and depression tend to drive alcohol misuse in lots of different populations. But, here's this emotional numbing symptom showing back up, and this is in a statistical model that included depression. So there's still something about PTSD numbing that is informing alcohol misuse. And as I'll mention in just a minute, this is somewhat different than historical models trying to understand self-medication in PTSD. My colleague Jessica Cook, who's a smoking cessation researcher, took the sample of veterans that we had referred on to mental health care to look to see whether or not PTSD was associated with smoking. In Vietnam-era veterans, we know that it is. People that have PTSD are more likely to be smokers, and they have a harder time quitting smoking than veterans without PTSD. But is this going to be true for people that maybe have just started smoking? Is this true for people that are light smokers? And so we looked at this clinical sample and found that, in general, PTSD is predictive of smoking status. People with PTSD are more likely to be smokers. But really, it looks like this relationship is driven by those that are heavy smokers. The folks that are the heaviest level of smoking, those reporting 20 or more cigarettes per day, in that group, that's where the PTSD symptoms were predicting their smoking status. And when we looked at the symptom clusters, it looks like I'm setting this up, but this is, when I look at the symptom clusters, emotional numbing shows up again as the only PTSD symptom cluster that's predicting nicotine use, heavy smoking. So the self-medication models for PTSD have typically thought of alcohol use as a strategy that veterans might use to dampen the hyperarousal symptoms, that they're drinking in order to deal with being out in public. And several papers have shown that to be true. But in our samples, what we're seeing is that both PTSD and nicotine use seems to be driven by this emotional numbing, interpersonal detachment cluster of symptoms. And it's hard to know. There's theory and research to support both the relationship where PTSD is, people are using alcohol in order to numb out to negative emotions. Deb Kaysen has done some wonderful work on this relationship between PTSD and numbing to self-medicate. But it's also possible, and there's literature and clinical evidence to suggest that people are also drinking and using nicotine in order to feel good. I need to get through this fog of numbness, and the only way that I can have fun is to smoke those 20 cigarettes. I need to enhance my mood in some way. By way of transition, though, one of the things that we know about not only PTSD from other cohort veterans, but substance use, including nicotine use, is that it does increase the risk of suicidal behaviors and suicide. And so I'm going to describe now a series of studies that we put out specific to the issue of suicidality. And the rates of suicide in active duty DoD have doubled in the last 10 years. There are tragic stories, local stories within the month that grab our attention around this issue. Historically, there's been a bit of a debate, though. Is it the PTSD driving elevated suicidality, or is it the depression that's so often comorbid with PTSD? Depression is what most of us think of as the disorder linked to suicide. And so we looked at those veterans that we had referred on to mental health care and included in a model PTSD symptom severity, depression, alcohol use, and drug use. And what we found is that PTSD was an independent predictor of increased likelihood of having suicidal ideation. I think what was remarkable to me was that 45% of our sample had reported some level of current suicidal ideation when they had come in. And I think we knew this. We were certainly being attentive to it, but sometimes the numbers just jump out at you. As did these numbers that 3% had reported a suicide attempt in the 4 months prior. So if we're seeing 15 or 20 veterans a week in our clinic, every month, we're 2 or 3 folks are having made a suicide attempt before they came in. We looked at the complexity load. Is PTSD a risk factor? And the answer is yes. Does the presence of one or more mental health disorder increase the risk of suicidal ideation? We didn't find it for PTSD plus one disorder, but we did find it for those folks that had PTSD and 2 or more disorders. They were almost 6 times more likely to report suicidal ideation than those with PTSD alone. And if you remember the pie chart where 27% have 3 or more mental disorders, this starts to paint the picture. The folks that are coming in with a lot of complexity are thinking about death. They're thinking about suicide quite often. We also did a follow-up study on this same cohort referred on to mental health care. This is another study driven by clinical observation. I can't tell you how many times I've gone out to the waiting room and there is a spouse or a mother waiting nervously, gripping a purse while the veteran comes into care. In fact, many of the veterans that I see say, I'm here because my parents brought me here. I'm not sure I want to be here. And more on that later. But these relationships were there, and I think lessons learned from prior conflicts, I think as a society, as a culture, we have really worked hard to send out the message to returning veterans that we support them. Whatever our thoughts of the military conflicts, we support them. So there's social support available, but the relationships that I was observing were strained. The person was waiting in the waiting room, but the veteran wasn't making eye contact with them when they came back. And so working with Stephen Vinoy and some other colleagues at the VA, we asked this question. I wonder if the protective factors of social support, the presence of having someone in your life and your satisfaction with those relationships is any less protective for suicide risk in those veterans with PTSD. And what we found is if you are married, you are less likely to be at elevated risk. Sorry, let me back up just a little bit. I had mentioned in the last slide that 45% had reported some level of suicidal ideation. We restricted our definition for this paper. We were only looking at those folks that had made a suicide attempt in the months prior or were reporting moderate or higher levels of suicidality. They were saying, I'm not sure I can control my impulses for suicide. I feel at least moderately or stronger that I want to die. So this is a higher level of suicide risk. These are the kinds of folks that you think about walking over to the ER. Marital status was protective. Those that are married are less likely to be classified as such. The interaction between PTSD and marital status wasn't significant. So being married helps whether you have PTSD or you don't. But then we also looked at people's subjective reports of satisfaction within their social networks. How happy are you with the amount of time you spend with people? How well do you think these relationships are going? How supportive are these relationships? And in that case, we did find our expected interaction. Satisfaction with social support is also predictive of suicide. I mean, it's protective for suicide risk. But if you don't have PTSD, there's an 80% less likelihood that you're going to be in this high-risk category if you've got very high social support. But if you're in the PTSD group, you're only about 40% less likely. So even if there is social support available to you, when you have PTSD, that protective nature of your networks isn't as strong. It's diminished. This is the final paper on suicide that I'll present, and this we came full circle with this. The original question about subthreshold PTSD and anger and aggression. Someone asked a question during a talk, and I thought, that's a good, I wonder. I wonder. And so we went back to the data and looked again at those with minimal or no PTSD, those with subthreshold PTSD, and those with what we consider high PTSD symptoms, likely PTSD symptoms. Those in the subthreshold group were 3.5 more times likely to endorse moderate or higher levels of hopelessness or suicidal ideation. Those in the PTSD group were even more likely than those in the subthreshold group, at a 3.5 times greater likelihood. But when we compared the subthreshold and the threshold PTSD, again, we didn't find any difference. So the subthreshold group wasn't any less likely to be reporting hopelessness or suicidal ideation than the full PTSD group. And we had asked, in this portion of the data, we had asked whether or not they had come in and seen mental health in the 6 months prior to their intake. And those in the subthreshold group were indeed less likely to have seen mental health. So our concern that these folks are slipping through the cracks seemed to be supported with these findings. I mentioned the historical focus on depression. In veterans, there are lots of reasons to be able to imagine how the PTSD and the combat service is informing suicidality. The emotional numbing and dysphoria symptoms, Peter Zach at Yale has done this in a study of OIF veterans and found that, once again, it's that symptom cluster that tends to be most strongly associated with suicide risk. He also, incidentally, put out another paper confirming that subthreshold category is at elevated risk. When we think about Thomas Joyner's theory about who actually completes suicide, people that have become somewhat accustomed to the thought of death, people that feel isolated, detached from others, and that perceive themselves to be a burden to their family and friends. In a lot of ways, that captures what we see in many returning veterans. By nature of their service, they overcame this idea that they are at risk. The nature of their job put them in situations where they had to be ready to die. And so they're coming back, and many of them will describe quite poignantly, I remember that day when I decided I was ready to die. It was a profound moment. It was a switch. And so they've already passed that first threshold, right? They have thought and considered and been open to death. And then they're coming back, and symptoms of PTSD, the isolation, the numbing, and the detachment are creating barriers between them and their social support. And unfortunately, this perception that they are a burden to others in some ways is supported by the literature on caregiver burden in veterans with PTSD. The relationships do have a significant negative impact on the friends and family of veterans with PTSD. Violence, drug and alcohol use. So these relationships often are quite damaged, and the loved ones of veterans are often quite worn out from dealing with these symptoms. And also, it's just important to acknowledge that veterans are at elevated risk relative to the general population for other factors. They are more likely to be men, and men complete suicide much more often than women. Veterans are also more likely to have access to firearms. I'm from Montana, and I've learned to talk very carefully around my veterans about what it would be like to give up their firearm. I usually use the Montana line as something to give me a little credibility. But also issues of homelessness, financial strain are common in our veteran population. So I hope I have created this picture of these veterans coming in with multiple risk factors, multiple complexity. And let me assure you, those of us at the VA and at the DoD and many dedicated providers here in the community are eager and ready to jump in and help these veterans. So what's the problem? Well, less than 10% of the veterans that have been diagnosed with PTSD or depression are attending the 9 or more sessions following referral that we would think necessary to deliver evidence-based psychotherapy. So if it takes 10 to 12 to 20 sessions to deliver prolonged exposure or cognitive processing therapy, to regularly engage veterans in harm reduction, suicide risk reduction, most of them aren't coming in frequently enough for us to do our job, right? Recently, a friend and colleague down in the Texas VA system reported this naturalistic observation study of Iraq and Afghanistan veterans who were referred to a PTSD clinic for prolonged exposure, or CPT. These are evidence-based psychotherapies for PTSD, the ones that have some of the strongest evidence for effectiveness. And almost 70% of the folks dropped out before they were done with treatment. Fortunately, the veterans are still coming back into the VA for care. Unfortunately, they're coming into the venues like primary care and specialty medicine. That may be because their health complaints are a greater priority. It may be because they'd rather go see a doctor than a shrink. But they are still in our system, and they are still floating around. There are other issues that we think are probably informing that low level of engagement. I mentioned my interest in gender norms, specifically masculinity. And in the packet, I had included several items that I had taken from a masculinity measure that captured, I thought, this issue of stoicism. I shouldn't let other people know that I'm upset. It's my job to stand on my own 2 feet. No one respects a soldier that asks for help. And these 3 items of stoicism not only predicted veterans' self-reported barriers to care, their perceptions of stigma for seeking mental health care, their perceptions of practical barriers to coming into care, and their mistrust of mental health providers. So incidentally, it was, I think, 38 or 39% of the variance in perceived barriers. So stoicism was this huge factor. But stoicism was also predicting PTSD and depression symptom severity, and there was a trend toward alcohol misuse. So it's a chicken and egg. This is cross-sectional correlational data. We don't know, but it's possible that people's determination to be self-reliant is informing greater symptom distress over time. There has been a lot of attention paid to stigma and barriers to mental health care. In fact, people are designing outreach programs probably as we speak to address these things and let patients know it takes the strength and courage of a warrior to come in and seek help. That's one of the magnets that we give people when they come in, right? Kate Herster, who was a former MIREC, did a great study. We used our clinic data and then went back and got permission to look at the veterans' actual utilization after they had come into deployment health clinic. And what we found was somewhat unexpected. The folks that went on to use more mental health care in the VA were also, at the bivariate level, more likely to report stigma, mistrust, and barriers. So it was the opposite direction of what we expected. When she threw everything in the mix in a multivariate model, barriers fell out, and it was just PTSD and depression symptom severity. The people that were more distressed came in more often. But I think it started to paint for us this maybe better way of understanding the role of stigma. People know that they need to come in. They are coming in, but they are indeed very ambivalent about coming in, and they are worried about what it says about them to come in. And I think as a therapist, that's important information when I sit down and talk to someone. They're here, they're showing up, it gets counted as a visit, but the quality of what we do may be hindered by their mindset when they come in. Several other studies have found that there are other barriers. Negative beliefs regarding mental health care. I don't think it'll work. I tried meds. It's not going to work. Fear of losing jobs. A lot of our veterans are coming back and seeking law enforcement jobs or want to stay in the National Guard or the reserves. And anecdotally, many of them have described losing their jobs or being told, I'm sorry, but I don't think this is going to work out. It's illegal. They know it's illegal, but the diagnosis of PTSD sometimes is a career-ending diagnosis. Certainly the time commitment required. With younger veterans, our older cohort of veterans, many of them are service-connected. They are retired. They have more time to come into the VA for care. But younger veterans that are still working and managing children and trying to figure out how they're going to fit the 45-minute commute over to the VA, those veterans are having trouble finding the time to come in for care. And as I've already mentioned, there have been several studies that have shown that veterans' reluctance to revisit traumatic memories, such as their discomfort at going back, that's a feature of PTSD, so it's not surprising that that's a barrier to treatment. So I'm going to just briefly describe some of the things that we are trying to do to address these barriers. If you can't you can lead a horse to water, but you can't make them drink, right? You can also pick up the bucket and follow them around. So we are working at ways to bring PTSD treatments into the settings where the veterans are actually showing up for care. So Brad Felker, I'm a co-investigator on a study that Brad is doing to modify our collaborative care models for depression to include tools specific to PTSD. So if folks don't know, a collaborative care model is usually a medication started by a primary care provider, a nurse care manager following the veteran to see if there are any problems with the medication, engage them in care, and to try to facilitate a higher level of engagement, psychotherapy, referral to specialty PTSD if necessary. We know this works well for depression. There have been several studies from investigators here that show that it works in the civilian population. The VA just completed a large multi-site trial, and it's not clear if just doing this and tacking on PTSD is effective in a VA. So we are actually looking from a perspective of implementation. What do we need to do? What kind of tools do we need to add? And that includes screening measures, but it also includes a lot of self-coping, self-management referrals, websites, the phone app, the PTSD coach. All of this work is based on a successful pilot study that we did at the Seattle VA, where Brad, Kate, and myself looked at, and others looked at telephone care management as an augment to usual care for OIF veterans, and we found that they liked it. They liked getting the call. There was no problem getting the call. They felt more connected with the VA care. As a whole, there was a significant reduction in PTSD symptoms. It was just a small open trial, but it looked like people were getting better. Unfortunately, when we looked at how many of them were getting reliably significant improvements in their PTSD, it was only about half. And about half of them started meds, and about half of them didn't. And the half that didn't received 2 or 3 counseling sessions. So there's room for improvement. Parallel to that, Amy Wagner and I have been conducting a 2-site study looking at behavioral activation intervention. We've taken behavioral activation, which is also an intervention for depression, and we have tailored it specific to PTSD, in part thinking that when people are first coming back, if they can re-engage in relationships, if we can help promote activity in really important parts of their life, spirituality, relationships, if we can help them get back into school, that this type of behavioral activation approach may help augment the natural recovery process and may minimize distress. If nothing else, it's probably a better tolerated intervention as a first step to veterans. If you think about the way you would introduce behavioral activation to a veteran versus the way you might introduce prolonged exposure, I'm not setting up PE to be a straw horse here, but I want to sit down and talk about the things that were most distressing to you, and the goal here is to get you to process those feelings and those emotions so that you can get used to them. And the 23-year-old Marine says, "I'll see you later, Doc," right? Or you say, "We're coming up with a plan. I'm your coach. How often are you hitting the gym? How often are you hanging out with your friends? Why aren't you emailing people back? Let's come up with a way to get you re-engaged." We don't think that it's going to be a more powerful intervention. We think it may be better tolerated. In fact, we're just about done with recruitment, and preliminary results suggest of the first 60 or people that we have come through that retention in BA is much better than referral to specialty care. Those in the BA condition are getting about 6.5 of our proposed 8 sessions. When we refer people to the PTSD clinics for whatever it is that they want and whatever it is that their providers are willing, want to give them, they're getting 1 med visit in 6 months, and they're getting 2 or 3 individual sessions and maybe a group session. So we are just seeing them more often in our behavioral activation intervention. So I want to end with this quote. This is a favorite quote from Jonathan Shea, who wrote Achilles in Vietnam. I think it captures our mission as providers, but also as a society, to help the men and women that are coming back from war. The quote reads, "Help him lay down weapons, maintain sobriety, meet health and nutritional needs, terminate current violence as both a perpetrator and or as a victim, and eliminate danger-seeking behaviors." So it's an important mission. It's not going to be an easy mission, and as Iraq finishes up, I expect that we aren't even halfway through that mission. So I hope I've left plenty of time for questions or comments that people might have.
We've actually worked on it. We send you a lot of patients for conversations like that. Matt actually has done some incredible things with folks from DOD and VA who end up here at Harvard Review and are laid up for injury and have VA benefits. So, really tough cases, public cases. So, coming back, CPT and prolonged exposure, certainly, it's almost like there are mandates for them now in the VA, and those dropout rates are interesting, the 68% dropout rate. But how do you see sort of working at a policy level with an institution that's so focused on these traditional therapies, like getting something with behavioral activation or the anger management piece into what's kind of done, but at a policy level in the VA, how are folks thinking about that? Are you using your research evidence to sort of promote that?
So the question is within the VA, which is fairly structured, is there this kind of
Soviet 5-year plan?
Is there this mandate for prolonged exposure and CPT, and how are we going to implement these more flexible alternative modes of delivery?
That deal with the risk behaviors, the other comorbidities, and the increased reach or breadth of applicability that you're describing, say in a VA protocol.
Right. So the larger reach, the better tolerability. And let me just say, a lot of the thinking behind our behavioral activation comes from Doug's work and this idea that you carry a bucket around with you wherever you want to go.
Have you ever heard Eugen talk about the cheap suit that the care managers like for the year of collaborative? Like a cheap suit on the patient.
That's right. That's right.
Yeah.
Well, I first want to note that I am broadcasting to the VA right now, so I'm gonna, but that usually doesn't. Yeah.
That's right. Dr. Reese is also a employee, as am I. So.
No, all joking aside, I think it's very much. I see this as part of the benefit of the work that we're doing is to try to get the system to understand that we need multiple different approaches and we need multiple strategies, and that the stakes are very high. I do prolonged exposure. I do it every week. I'm not afraid to talk about trauma with my patients, which is sometimes been accused of me because I'm offering something other than behavioral activation. None of that is true. But the one-size-fits-all approach leaves about half of the veterans, half of any PTSD patient, not sufficiently recovered, and leaves a significant number of them dropping out of treatment without any follow-up. So I would propose, and I think perhaps we represent a growing voice that says better to treat more people with something that might be slightly less efficacious, but perhaps more effective because it reaches a larger population. And I think it's a conversation that's going well. I think especially using the primary care mental health integration initiatives is the best portal of entry. We're kind of throwing up our hands and saying, if you want to do PE and CBT with this veteran in specialty mental health, terrific. I'll let you know when I can get him there. And otherwise, here's what we're going to be doing with him or her in the meantime. And I've seen it work both ways, where people come back to primary care mental health with that sub-threshold symptom cluster still present. And they still need some sort of treatment. So I hope that answers your question. Yes, Dr. V.
That was very nice, very thoughtful and comprehensive presentation. I was struck in the earlier papers around this dichotomy between the subthreshold and the full PTSD, and it looks like they're more similar than different. And wondered if you talk a little bit about those don't look to be categorical sort of differences, maybe more dimensional. How, for example, reliable is someone who gets identified at point A as having subthreshold that 6 weeks, 2 months before, they were in fact experiencing more symptoms. So you can talk a little bit about that issue and how it affects your approach to your data analysis.
Of course, yeah. So the question, the comment was that really in some ways, rather than these being three discrete categories, it looks as though PTSD is this dimensional reaction. And there's some strong evidence to support that that's not categorical. As far as I think if I understood you correctly, how do we understand and how do we anticipate this fluctuation from perhaps subthreshold into threshold and then maybe from threshold back down to residual symptoms? There's in the delayed onset literature in PTSD, there's a lot of evidence to suggest that people with subthreshold symptoms are more likely then to go on and develop full PTSD later. Still a question in my mind whether that's that they're not just disclosing all the symptoms right away, but often psychosocial stressors will exacerbate underlying symptoms, and suddenly someone will start having some of those re-experiencing symptoms that they didn't have when they first came back. So I think there's literature to support that. And if you look at the treatment trials of PTSD, a lot of folks are completing treatment and they're showing significant reductions, meaningful reductions in their symptoms, but we wouldn't say that they are back to baseline. And in some ways, I think, I don't know if this is a task for DSM-6 but depression has all these modifiers that allows you to comment on whether or not this condition is in partial remission or if this is recurrent. PTSD is thought of as something that you have or you don't. At least it's often treated that way. And so if I'm going to sound a little bit cynical here, but if you're doing a clinical trial and a PTSD score suddenly drops below the magical threshold, you've treated them, you've cured them, even though they may be in this subthreshold range and not optimally enjoying their life.
Well, there were two things that made me think of that. One relates to the depression literature. If you meet subthreshold depression criteria on a population basis, those people use a lot more resources or have much higher risk for a lot of things. The other was an allusion to the historical observation that there were a lot of people who didn't show up as either declaring, receiving, or expressing PTSD from the Vietnam era, who once these wars got started, and certainly when 9/11 happened, suddenly blossomed forth. And you can ask the sort of a categorical, dimensional question. Well, did they have PTSD that was just well managed or, well compensated or not? So it's a tricky question for research intervention.
It is very tricky for research. I think it's also very challenging for a clinician to know when you are feeling like this patient is ready. And I always say, here's my number, put it in your wallet, leave it in your wallet. The other thing this makes me think of it, as long as I'm out on a political plank, the rates of PTSD down at Fort Lewis are not nearly as high as the rates of adjustment disorder. And there are financial implications for the Department of Defense, and there are financial implications for the VA once a diagnosis is given, right? And the process is lengthy to get service-connected for PTSD. I've seen firsthand that it can actually be quite abrupt when that reduction in level is made. Oh, you're doing better. I think there's another perspective here, which is not only does the disorder likely fluctuate, but what we call it has a lot of implications for the cost of treating it. Yes, sir.
Yes, the few veterans that we have encountered here, I noticed some enjoy talking about themselves, enjoy even war experiences, not just in general. And then there are those that just don't like to talk about themselves. I'm wondering how you approach those individuals, what tricks you use.
So the question is, what do you do with the folks that are very reluctant to talk about their experiences and talk about kind of what brought them into care?
Yeah.
I move very slowly. I will typically lowball the offer for psychotherapy and say, well, why don't we just meet a couple more times? Let me tell you what I know about this stuff. If that's all you want to do, fine. So we definitely use a lot of motivational interviewing, but I feel as though if I can get a veteran to come back and see me 2 or 3 times, even if they won't continue immediately, those are the veterans that I see again 6 months later. They've gotten over the fear and the anxiety of calling Dr. J on the phone, and so they know how to do it. And in some ways, I think bringing them into primary care is an opportunity for them to learn how to seek help. And so even if we're not digging into the nature of their PTSD, as a behaviorist, I'm reinforcing the heck out of that behavior. Come in. Great to see you. How have you been?
Finding any difference in terms of how they respond to the background of the therapist? I mean, most therapists are not people who've been to war or the armed forces. Is that different?
The question is, does the therapist's identity and background have an influence? I think definitely so. Brad Felker, our psychiatrist, was actually deployed himself, and I know that gets him all sorts of credibility. His patients stick with him with a loyalty that is probably stems from armed service. I'm always very transparent about what I don't know about war, and I offer that up really quickly to veterans because I think I learned early on as a young therapist wanting to justify what I knew and what I could do for them, that if I tried to oversell my credentials or oversell what it is that I knew about their experience, that was not often work out well. So I do come in with a very humble, I'm not sure I know what you've been through. I do know some things about how many people react to stress and react to war based on the stories that they have shared with me. And I usually use that explicitly. I don't know what it's like to be in war, but I've talked to literally thousands of people that have. Any other questions? Am I supposed to check in with the off-site folks?
Yeah, but there's no question.
Okay. If there are no other questions, I'm really grateful to be here. Thank you for having me. And if people want to see my slides or if they want reprints of any of the articles, simply email me and I'll send them along.